All right. Good morning, everyone. We are going to go ahead and call the order. Shelley, if we can do a roll call, please.
Brian Smith. Chris Salvino. Dale Woolridge. Dan Spade.
He came online earlier.
Oh,
Dan Spate's on the phone.
well, thank you. Deb Barambe.
Present.
Edgar Bissonette. Franco Castro Marin.
Present on the phone.
Gail Bradley.
Present.
Garth Gamer.
Here.
Glenn Kaepernick. Heather Miller.
Present.
Howard Reed. Eve Guthinker.
Present.
Jim Hayden.
Present.
Yossi Torres. Nick L.
Present.
Raymond Ochoa.
Present.
Rodney Reed.
President on the phone.
Roy Ryle. Sarah Parati. Please. Shari Brand.
Present.
Phoebe Merrill.
Present.
Todd Hermel.
Present.
Vince Martinez.
Present.
Vivian Gellert. We need to continue quorum.
Thank you, everyone. If we did not capture you during roll call, you can put a note in the chat and we will capture your attendance that way. Thank you, everyone who is participating today. Just a reminder for the attendance purposes, we do actually either see you in person, your face on the camera, or hear you or see you put your name in the chat so that we can capture your attendance appropriately. Also, another friendly reminder is that everything said and shared as part of this meeting is part of public record and shared to the Bureau's website. This includes both the chat and the camera footage as well. Your attendance report is in the packet. A friendly reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to see if you're still interested in serving on the committee. So just a reminder about that. Next, I would like to welcome 2 new members to the committee. So welcome Chief Ochoa and Chief L. So thank you both for joining the committee. And we have several reappointments. So thank you for everyone. We do have to wait months for the reappointments to come through. So we appreciate your patience with the wait for that. So just congratulations to everyone that was reappointed. So Vince Martinez, Franco Castro Marin, Deb Barambe, Brian Smith, Todd Hermel, Garth Gamer, and Dale Woolridge. So thank you everyone for your continued participation in this committee. For vacancy reports, we do have 6 current vacancies. We recognize that we do know several people have put in for these positions. Again, we do not have any input into the appointments, but if you're interested, you can check in with Governor's Board and Positions to make the determination. So the 6 vacancies are listed in the meeting agenda. If you have a meeting term that expires in 24 or has expired, or if you're interested in filling a role, you can go to the website listed on the agenda. So the Governor's Board and Commission's website, and it has the information on how to apply. Next, for just a brief update on the naloxone Leave Behind program. So I'm going to jump ahead a little bit on the agenda, but we would like to welcome Dave Hansen, who had joined the Bureau as our new individual over our FR Care program. Comes to us with extensive law enforcement background, as well as experience with the FR Care grant. So great addition to the Bureau. I think on last count yesterday, I was asked, we're up to 21 agencies across the state that are participating so far in the naloxone Leave Behind program, which is great. So many of those are in the training phase of this, but we do have some agencies that have the naloxone Leave Behind kits that have been distributed. If you have any interest in participating, have any questions, you can link the website, then click the agenda, and that has all the information on how to apply to be part of this program. But we're really excited to see such robust involvement so quickly in the program going live. The 2024 meeting schedule is also in the package. Just a reminder, these are calendared out the entire year. So we will meet again next in May and then September. I will turn it over next to Chief Garcia for zero report.
All right. Well, we already got the opportunity to welcome Dave. And we also have in the back of the room our other newest team member, Mike Hamilton. He is our GIS guru. That's your official title, right? Guru. Comes to us also with some really great experience in both EMS and GIS. So looking forward to working with him as well. We have some bureau update slides that I will not go through in great detail, but we'll go through them quickly and they will be distributed as part of your meeting packet today. We have a quick update here on the EMS and trauma system. I heard that we actually, since making this slide, hit 22,000 EMCPs in the state of Arizona. And we are going to talk a little bit more about how we're going to get better numbers on the number of actively employed and working EMCPs in the 911 system over the next year. Going to our next slide. We wanted to make sure we're sharing with everybody that based on our appropriation this year, that it's just over $4 million. We were able to carve out $850 off, or $850,000 right off the top, and slide that over to our 4 EMS regional councils for rural education and training. And we're really grateful to the 4 regions we have represented here today that have really helped to build out the rural paramedic training program and the number of students that we know have participated so far in paramedic training in all the regions as a result of this funding. Our goal as we work with the regions to build out our strategic plan over the next year is to make sure that we are continuing to demonstrate the need for those funds and building out that workforce even more in our states. In the next slide, you'll see some of our 2024 top priorities. At the very top, we are going to be completing our EMS and trauma needs assessment and strategic plan this year, as well as focused on rulemakings in the realm of EMS workforce development and training. And we'll talk a little bit more about that in the next few slides. So going on, we're going to hear today from Julia a little bit about the strategic planning process. And I won't spend too much time here, but in the next slide, we do want you all to know that we will be gathering more input on that strategic plan and needs assessment in the coming months. And by September, we hope to come back to you all and EMS Council to get your buy-in on that strategic plan that we're preparing. But we'll talk more about that in a bit. Moving on, I want to talk legislative and rulemaking updates very briefly. This is the slide where you'll see the bills that were passed in the 2022 and 2023 session. Nothing new here for EMS Council. You all know about these bills. We wanted to keep them here for presentation purposes today, so everyone knows that several of these bills did not go into effect until January 1st. We've been talking a lot with stakeholders about House Bill 2609 in particular. That bill did not go into effect until January 1st of this year. In 2024, we are beginning to review some of the bills that have been filed so far in the realm of EMS. House Bill 2290 is Certificates of Operation and Interfacility Transfers Bill. House Bill 2066 is the Behavioral Health Transportation Bill. The department is still reviewing these. Do not have an official position or anything to share yet today. We are still looking at them. The bills for now that we wanted to draw EMS Council's attention to are the ones that have the asterisk next to them. These are the bills that authorize exempt rulemaking for the department to update certification and training rules in 2024. That is something we will be focused on. So moving along, a quick rulemaking update is the last 3 bullet points you see there. This year, we are going to be continuing our work on the ground ambulance rulemaking. We are also going to be working with our committees on certification and training rules, as well as scope of practice. That will be our rulemakings that we are tackling this year. Going on to the next few slides, I'm going to talk a little bit about emergency medical responders, and then we'll talk about the ground ambulance rules package. I won't cover these slides in great detail, but I will make sure that we distribute these out to everybody. So Shelley, I'm so sorry, I'm going to ask you to go back 2 slides really quickly so I can read these. This one right here. So we did have our EMS Council Ambulance Safety Work Group, as well as the department review the new EMR ambulance driver laws to provide policy recommendations. And for those of you that participated in that ambulance safety work group, we did convene that group twice at the end of 2023. As they got together, that group did provide recommendations to the department, including age considerations for EMRs, as well as emergency vehicle driver training. And that was looking at the national standards to make sure that we are moving forward with national standards as much as possible. In our next slide, the department did a further review on the new EMR laws and the recommendations that were provided so far. And we did determine upon further review that the EMRs, the emergency medical responders, at this time cannot be certified as an emergency medical care technician in Arizona. There's a definition in statute at this time that would need to be updated in order for the department to have authority to certify emergency medical responders. EMRs can provide interfacility transport, but we also want to note that there is a discrepancy in the statute. Although an EMR can provide interfacility transport, companies cannot bill for all services at this time. They cannot be certified in Arizona. And then finally, our regulatory authority in summary over these non-certified ambulance drivers, it is currently limited to certifying the EMR training programs only, and following that up with developing a scope of practice. That is really where our authority lies here. So going to the next slide, Shelley. We do have limited rulemaking authority to address the EMR ambulance driver requirements. We will be looking at developing state standards. The rulemaking will have to address standards for EMR training programs and scope of practice, following the state requirements that are now in state law, in addition to the national standard. Again, we are not going to be updating our certification rules at this time. And the companies that do choose to use the EMRs will assume the risk and liability at this time. And we want to make sure you're aware that we'll be unable to bill for all of the services provided under the use of EMRs. So next slide on this one. We have been asked, can a company go ahead and use an ambulance driver at this point as of January 1st? The short answer is yes. But we want to make sure that anybody that's looking at this option in the event of a workforce shortage understands the limitation in the statutes with respect to how EMRs can be utilized. Under the statute, a non-certified ambulance driver is limited to the following circumstances. It can be an ambulance company that is serving a rural or wilderness CON area with a population of less than 10,000, or providing interfacility transport. There's still a requirement to have at least 2 ambulance attendants, and that would require either at least 1 certified EMCP or licensed nurse or physician, and at least 1 certified EMCP or EMR. And we just want to make sure that folks know that the use of EMRs is limited to those circumstances. Next up, I do want to jump into the ground ambulance items that we have gone through with many of the stakeholders throughout each region in the last week. And I know there's some hands raised. Roy, if you don't mind, we'll go ahead and go through the remaining Bureau report slides, and then we'll check to see if there are still questions in the chat. So on the heels of this, we did go through ground ambulance rules informational sessions, January 8th through the 12th. The next few slides are a summary of what we provided holders who participated in those sessions. I will not read through all of these slides, but we do want you to know that these summary slides are available on our website. It includes a crosswalk of the new statutory requirements and the new rule requirements. In the next few slides, you will see the new CON response time reporting requirements, as well as the ambulance equipment requirements. And those 5 slides that we have inserted there, they are a summary of the rules package overall. Again, they'll be in the slides that we'll distribute as part of today's meeting. They're also posted on our website for anybody that would like to do a deep dive into a summary of all the rules changes. And finally, I just want to make sure we're covering next steps in the rulemaking process with this group. We do intend, as part of the updates that we've worked on with stakeholders throughout the last several years, we do intend to convene work groups and our special meeting sessions with several of our committees for subsequent rulemaking. We're going to be developing the state standards for not just EMR, as we talked about, but also critical care paramedics, and laying the foundation by establishing scope of practice for those EMS providers. We also will be getting the rules work group back together to discuss inter-facility transport reporting requirements. So those will be the rulemakings again that we will tackle in 2024. We will make sure to keep EMS Council and our stakeholders updated on any upcoming rule meeting. And so that information will be coming to you. I'd like to turn it over next to, we have Julia, TJ, and Lethia on the line to give some additional updates, and then we can do some questions in the chat.
All right, I can just give a quick update on the SHARE program. So we are in the final stages of migrating the ADD and feeder registries over from the University of Arizona. We have completed moving over the AED registry, and we have a new URL for that, aed.acj.gov. We're anticipating that the new feeder site will go live in early February. We're just working on testing right now before we move all of the data over. When we complete that, we'll be able to start working on linking the EMS console data and start working on 2023 EMS and our share reports. So please feel free to reach out if you have any questions. Myself or Adam Rodriguez are happy to take any questions.
Very much, Julia. You guys have seen this naloxone leave behind slide before. It's now been updated with Dave's contact info, so you guys have the enhanced contact info. Shelly, can we go to TJ next? Is TJ on the line?
Yep, I'm here. Sorry about that. Good morning. So National Registry updates, they are working on some updating of their purpose, mission, and vision statements. They've been doing some research on how that messaging is getting out. They did some self-studies and have already surveyed the state offices. They're going to be coming around to the program directors and training officers in the near future. So if you see an invite, they would very much appreciate your input on how they are doing as far as their messaging is concerned. The evidence-based guidelines, the new ones are up. They keep updating those. A lot of their testing is going to be based on a good deal of peer-reviewed work. They have updated the NCCP model with the evidence-based guidelines. There's a link to all of those papers with the consortium there that you can look through. Just as a heads up, the folks that are recertifying through National Registry, up until 9/30 of 2025, they're going to be using the 2016 model. They've updated it and removed a lot of the subcategories, so it's a broader subject-based model now with some equivalents given for those standardized courses like ACLS, PEP-PALS, and things like that. Anyone expiring after March 31st of 2025 will be under that new model. So there's references and charts for both of those in that link. There's also some links to their current resolutions and key initiatives. They're working on an occupational risk study. They've just got some funding for that, looking at all the potential hazards that EMS and fire are providing and they're exposed to on a regular basis. It's going to be one of the most comprehensive studies that's been done on the subject. And then workforce study, it's actually kind of a unique one. They released it last year, but it has the 9 states or the 9 political subdivisions that require National Registry for recertification. And it kind of shows a lot of the movement and inflow and outflow of personnel into the field. So some really good details there on what has happened with those folks because they have the captive data and it kind of reflects what's been going on nationally as well. So unless anyone has any questions for me, that's all I've got. Feel free to give me a call if you have any questions. Thanks.
Thank you so much, TJ. Next up, we have Lehia Castro, and I'm not sure if we also have Ann on the line, but Lehia, would you be able to tell us about the most recent update to the EMS portal, including how we can do a roster survey with folks?
Yeah. So we have made some updates to the system. So now that we're transitioning to our license management system, the last step that we have to do is merge or sync the license management system with the lead. So I'll let Ann talk more about the syncing with the LMS and the lead, and then I can come back and go through the steps of how to update the provider rosters.
Morning, everybody. This is Ann Bosbrink, the EMS Data Manager for AZ Peers. I'm going to kind of assume that everybody on this call knows what AZ Peers is, but it's the EPCR system where you have all our patient care records that are pre-hospital that come into our system. And as I'm sure everyone also knows, we have the newer licensing management system, also called the Trauma and EMS Portal, that's handling and organizing a lot of the activities that we had kind of spread out previously or were handled by our older system. And one piece of this that I am super excited about is the rosters, which I know we had roster management in the old system. I wasn't super familiar with the old licensing system, but I wanted to talk just really briefly about what this piece has to do with AZ Peers. It's obviously good on its own merits of managing your roster and knowing who you have and allowing the state to, I think Rachel mentioned a little bit earlier, allowing the state to be able to know who is actively employed in the EMS agency and those sorts of things. But the syncing will be something that allows us to have one system of record. That'll be the licensing management system as far as personnel and the basic information that you would put in, so it doesn't have to get inputted twice. One of the big issues is things are never the same between the two systems, which, you know, is a security issue, really. We want to address that, plus just make things more streamlined and easier, no double entry and things like that, so that the roster updating in the licensing management system, that should be very straightforward, will sync over certain details to AZ Peers Elite, and those personnel will then be the list from which you as agencies can pick if you want people to have access to AZ Peers, if you want them to get certain data quality reports or be added to certain lists that I maintain of primary contacts and that kind of thing, so that there's not two different places. One thing that I have noticed is we sometimes don't have a great way for agencies, unless they remember to tell us when someone leaves an agency. And although we haven't had any issues, I would really like to lock that down and make sure that everybody, and we put kind of the control back in the agency's hands. It's also going to reduce delays if I'm out. It doesn't matter if I'm out, because if you update it in your roster, it's going to sync over. We're obviously going to have a clear picture once we start working with our first agency and kind of, I won't say testing it out, because most other states do this, but at least we're going to see how it works for us. And I know we'll be sending out additional information in the near future, so do let us know if you have questions. And I'm going to hand it back to Lehia now, who's actually going to tell you the important part, which is how to do it.
Thank you. So we can go over to the next slide. So I think if you are a CON holder, you should already have access to the system. If no, we have videos on our website on how to do so. But once you log into the system, you're going to click on provider. Once you click that, if you work with multiple agencies, you'll be able to see them, but you're going to click the provider that you want to update the roster for. So you're going to click on the name. Once you select the provider, you're going to click on personnel. Once you're in this screen, you're going to be able to see the rosters, the current rosters that you have. If you want to add someone into the system, they must have an account in the system already. If they don't have one, they'll need to create one so you can add them to your rosters. But it's pretty simple. Under personnel, you just look for their name, just click on add. You just click on add, and then you'll be able to add them that way. That's the only thing you'll need to do. And then to remove them, it'll be pretty much, you just click on one of the, you just check mark the box, and then you'll be able to remove them from your provider roster. Something you can also do is you can download the roster to a CSV file, and you'll be able to see who's currently on your roster, and you'll be able to update that. And then once you see that, then you can go back in there and update the roster. In order to have access to a provider, you need to be assigned a role. So if you're currently a coordinator or a fleet manager or have one of the CON rosters, one of the CON roles, you should be able to access the roster and update the roster. If you're a CON holder and you want to give access to someone else, please reach out to one of the regional coordinators. If you're not a CON holder, you can reach out to myself and Ann, and we'll be able to help you out with getting access to your agency. And something really cool that will be launching as well, if you're a non-CON holder, you'll also be able to update your provider demographics.
Leah and Ann, thank you so much. This is awesome to provide the overview. So in summary, the benefits of this are if you go into our system and you update your roster, number one, it helps to automatically update who has access in AZ peers. There's a couple more steps involved, but you know, that's the gist of it. And selfishly, as a state, if you also go in and update your roster, we all benefit, because we will now have insight into how many actively employed EMCPs we now have in the system in the state of Arizona. Right now, if asked that question, we'll tell you we just hit the mile marker of 22,000 certified EMCPs in the state of Arizona. Without updating these rosters, we can't tell you who is actively working and who is just holding a certification right now. So we really appreciate you guys helping us spread the message. We'll keep promoting how you can log into the system and update your rosters, and we definitely look forward to getting eyes on what that looks like and enjoying the benefits across the system as well and AZ peers. Any questions on that? I think we probably have some questions in the chat to go to, folks that have been patiently waiting. Thank you for letting us take some time on the Bureau report this morning. What questions do we have quickly? Yeah, Roy, I'm sorry we've had you waiting. We'll go to you and then Brian next.
Thank you. Just a quick question, Rachel. You said in terms of the EMR usage that they cannot bill for, quote, some services. What services can be billed for and what is prohibited from being billed for and why?
Thank you, Roy. Specifically under A.R.S. 36-2239, depending on how an ambulance is staffed, if there is an EMR and paramedic on the rig, for example, you can bill for ALS services. If there is an EMR and an EMT on the ambulance, you cannot bill for services. So it's specifically under A.R.S. 36-2239. And that will provide information on what services can be billed for based on the staffing of the ambulance.
Okay, thank you. Will that be solved, by the way, when the state starts certifying EMRs?
If the state has the ability to certify EMRs, then that would solve part of the issue, yes.
Thank you.
And then Roy, if you're wrapping up with your questions, we'll go to Brian next.
Just a couple of things. One is a comment on the CAPTCHA for when you do lookups that's been activated now. So like I have had 2 paramedic classes that we provided scholarships to. So like in the last couple of days, I've looked up 19 people and having to redo CAPTCHA like every other app that, you know, and then you're having to select how many motorcycles there are, how many bikes there are, sidewalks there are every couple of deals. I don't know if there's a way they can lengthen time before that makes you re-enter something, but it's kind of a pain. You're doing a lot of people at one time, which I have been. The other thing is, and under the old system as Flagstaff Medical Center and Base Hospital, I had everybody who put their name as being employed by FMC in the emergency department as a tech ended up on my list. And there was no way apparently to make Flagstaff Medicals, because we don't provide medical direction for them. We don't have anything to do with anything that goes on with those folks. If they're going to be a way in this system for them to become their, I don't know, their own agency or whatever, so all those people don't show up when I go look at if I got it activated, I would go in and see them. I don't think I can see them right now, but that was and you know, we got people that work at NAH and they put down on their EMT cert when they get put in their applications that it's NAH and they don't even work as an EMT and NAH, and they're all showing up on the list. So, and I apparently couldn't get rid of any of those either. So my question is all those people going to show up in this system, or is there a way to deviate the two departments from each other?
That's a great question. This is where Leahia Genius can come into play. And Leahia, if you don't mind, we'd love to follow up with you after this meeting because Brian raises some really good questions. On the security side, we can look at our policy to see if we have options in making that CAPTCHA burden a little bit less, Brian, to your point, on the roster side and how the EMCTs display in the system under an organization. Leahia can advise us on what the system is capable of doing and help with that.
Okay.
Those are great questions. Well, I think we have taken up a large chunk of time, and thank you very much for allowing us to do that. We will certainly follow up on the question, and we'll turn it back to Dr. Bradley.
Thank you. Next, Standing Committee and Regional Council reports. First up, Dr. Merrill for updates.
Hi there. Thanks for having me. Make it pretty brief, but for trauma committee, just for review, had a discussion and review of the House Bill 2609, review of AZ Peers resources on the website. Dr. Bradley was able to give us an update about the SHARE program as well as the dashboard for the MVT discussion. It also involved regarding drug and alcohol use, looking at sort of how we incorporate fentanyl results into that. And then lastly, the dashboard data, including discussion about hip fractures and how we best get that information, whether it's being captured or not. So if there's any questions, let me know, but that's just a brief overview.
Thank you. Next up, Brian for Education Committee.
Thank you. The Education Committee approved their minutes as was presented. We had a discussion on the EMR, who's not necessarily curriculum, but what the statute are going to say about how they need to be trained, and also had a similar discussion at the start of the critical care paramedic endorsement topics that will be coming up. We approved peds seizure training that was presented. We approved the peds airway training. It was amended. Both of those are now posted on the Bureau's website and are available for anyone to be able to go look at. The group agreed to a second work meeting for fall prevention training, date to be determined still. And then we have a review of all the training modules that are available, and we've looked at those every couple of years or so. There was a work group formed to look at sepsis, and then there was one person that's going to review the offline hands-only CPR, and then the offline safe sleep and BRUI. And there was some people that volunteered for the sepsis work group. Our next meeting will be March 21st, 2024 at 10:30 in the morning. MD.
Yes, thank you.
We approved our minutes as presented. We also approved our bylaws as amended. Had some discussion on the our curriculum and the critical care paramedic endorsement curriculum. We reviewed a triage treatment and guideline for behavioral health alternate destination. And then there was a request to add a category of IV antibiotics to drug table 1, and that did not pass at PMD. Our next meeting will be March 21st at noon.
Thank you very much. Next up, for regional council report, President Roy for Central Region.
Thank you. Apologize for getting the comprehensive report to Shelley prior to the last evening, so you have it, and was actually sent out this morning. I will defer to that, but I would like to highlight one area on the OBLS grant process. AIMS is very happy and proud to be participating in a grant process on OB advanced life support. The purpose of this 5-year OBLS training initiative is to study and train on OBLS throughout not just the central region, but the state of Arizona. If you'll go down just a little bit more in that slide, whoever's handling that slide or that share to the bottom of that, I want to highlight that if you'll read that information, I'd like to highlight that hyperlink there. Is that if in your area, this is a statewide initiative, and AIMS has a contract with the training program to help implement it on a statewide basis. So if you have an interest in having some of this training in your area, there's a form that's you can fill out to show the interest, and then we'll be in contact with you. And if you don't have can't keep this hyperlink forever, so you can get additional information just by calling Peggy Baker or reaching out to her through AIMS.org. So other than that highlighting, I'll just defer to the report.
Thank you, Roy. Next up,
Dr.
Jane. Oh, yes.
Could I just piggyback on to the report? I wanted to recognize the Bureau and thank the Bureau for expressing confidence in the regional councils to disperse the training funds to take EMTs to paramedic level in the rural areas. And we had, thanks to Peggy and Roy and Sandy Nygaard, we had a disbursement meeting, and we identified 9 agencies that are listed, and they will be able to send their EMTs to paramedic school. So again, appreciation publicly for support of the regional councils in that endeavor.
Thank you. Next for our streams report, A.R.S.
Good morning. Thank you, Dr. Bradley. I submitted our report recently as well because our meeting happens just before this meeting. So we don't have a lot of time prior to the end of our summary meeting and this one. However, the notable changes are that we had our annual meeting on Tuesday and our vice chair elections as well. Some of our sub-councils have already had their annual meeting for this year as well, which happens in January for several of them who also have new representatives as chairs. Our 2024 calendar has been reviewed and submitted. It's also published. I did attach it to this distribution. If you have any questions, certainly reach out. There are some notable changes to our 2024 calendar and when our subcommittees will be meeting. So if you have any questions on that, I can certainly answer that as well. I also want to highlight and thank the Bureau for the communication and the time spent on the ground ambulance rules information session. We got really good feedback. Our members were very appreciative of the support and the time given, as well as the structure and the ability to ask as many questions as they needed. So I wanted to make sure I called attention to that and just the positive feedback we got in the region. That's all I have other than what's summarized in my report, but I'm happy to answer any questions. Thank you.
Thank you, Sarah. Next up, Vince for name.
Good morning, EMS Council. I have submitted the names report. If anyone would like to read the details of our meetings and the great work that our membership is doing, it's right there for you. We do have one important announcement. And Shelley, can you move to the names Pediatric Symposium page? There it is. Right. So NAMES is presenting our 15th annual Pediatric Symposium on March 4th and 5th in Flagstaff, and we welcome you all to participate in the awesome pediatric educational opportunity, and you can come play in the snow. So please go to the NAMES website to register for the symposium, just to see what NAMES has to offer. And that is the summary of our report. Our next meeting is scheduled for February 2nd. Thank you.
Thank you, Ben. Next up, Rod, Western Region.
Hey, good morning. We had our January meeting on the 4th in Parker. At that meeting, we through the applications for our provider assistance program. We decided to fund $45,000 worth of provider assistance applications. I would like to echo what everyone's stated about the EMCT funding for scholarships. We have finished ours. We've used up all the money this year for, we were able to, out of that $100,000, we scholarshiped 10 individuals in La Paz County and 15 individuals in Yuma County. So super we'll go on there. Our next executive board is February 8th. It will be a virtual meeting, and the next in-person meeting will be May 9th in Lake Havasu, where we will work on our bylaws, doing some tweaking there, and we'll have elections for president and secretary positions. And that's all I have, unless anybody has any questions.
Thank you, Rod.
Yep.
Next up, Dr. Woolrich for a patient's report.
Yeah, hi, good morning, everybody. The Pediatric Advisory Council last had our meeting November 16th. At that meeting, we approved our meeting minutes as they were amended and our bylaws as those were amended. We did announce a vacant position for the Pediatric Advisory Council, and that's as the pre-hospital coordinator position for the council. If you are interested in that position and would like to submit your CV, please reach out to us. You can get that contact through Brianna or myself or through Shelley. Next, we did announce that the Pediatric Advisory Council is working in conjunction with the Arizona EMSC program to offer the didactic portion of the neonatal resuscitation program. That's available offline. And Brianna or Shelley, if you have that link, maybe we can put it in the chat or email us and we'll get you plugged into that if you're interested in that training program. Echoing comments that Brian had made earlier about the Education Committee, the Pediatric Advisory Council works in conjunction with the Education Committee for teaching modules. The most recent were that of the pediatric seizure training and the pediatric training management, airway management modules, and those were approved by Education in November and are available on the Bureau's website. Our next meeting will be March 21st, and we welcome everybody to attend. And if you have any questions in the interim, please reach out to Brianna or myself or Adam Rodriguez, and we'll see how we can help you out. And that concludes the PACES report.
Thanks, Dr. Woolrich. All right, next for our discussion and action item, if I can get a motion to discuss, amend, and approve the meeting minutes for September 21st. Thank you. Is there a second?
Second.
Thank you. The meeting minutes are in the packet. We'll scroll through those. Are there any recommended amendments? All right, hearing none. Anyone opposed to the meeting minutes as displayed, please say nay. Any abstentions? All those in favor say aye.
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 Thank you. Next, Shelley, if you can bring up the slide deck for the behavioral health alternative destination work group. If you wanted to bring back to EMS Council a follow up on the 3 work group meetings we've had regarding behavioral health destinations and alternative destinations. So I'll just give a very brief background for those of you that have not participated in those work groups. Historically, when you look at behavioral health patients, these patients have gone almost universally when EMS counted them to the emergency departments. Once those patients arrive in the ED, they often have a really prolonged stay. They take sitter hours. These are not patients you can necessarily put in the lobby. So typically you may have a patient that is on an ambulance already waiting for a medical bed that's actually much more medically ill because the room is being used for behavioral health patients. So there's a lot of trickle down effects that occur for this patient populations. And I think most importantly for these patients, when they go to the ED, they're not getting the clinical care that they need. They're not getting psychiatric care and evaluation. They're really waiting for placement at another facility. And so we decided to convene a group of stakeholders with invitation going to all of EMS council members to look and see what options we could do to address the patient population. Next slide. So we wanted to really identify what are the barriers to doing this? What are our barriers to getting patients to alternative destinations? We wanted also to bring together the stakeholders to cover the entire spectrum. So one of the things we really have tried to do is increase the awareness of what Solari and the 988 system provides in the state of Arizona. They're a great resource. They did a really excellent presentation at our first work group meeting, and I think really shares the volume of patients they help take care of and manage. And ultimately, our goal is to get the patient to the right destination the first time, but really create a sustainable model. We understand that with the current treatment refer reimbursement model, that was not a model that's really taken off, partially because it's really hard to sustain a transport at that reimbursement rate. Next slide. So we wanted to review the existing statutes and rules as they pertain to alternative destinations. We're not looking to replace existing infrastructure. We know that crisis response units and law enforcement already do a lot of these transports, and so we certainly don't want to intervene with that. But we recognize that there's a subset of patients that DMS is on scene, and for that subset of patients, can we potentially avoid taking them directly to the emergency department? So we really are looking to augment the system versus replacing what's already existing and functioning. Next slide. So we also wanted to really focus on behavioral health patients. We recognize that there are some jurisdictions that do alternative destination and treatment referral type programs for other more medical complaints, but that's much more complex because these patients often have issues with secondary transport, and really we wanted to focus it specifically to behavioral health patients. The other key thing is recognizing that we want to make sure we address the appropriate patient population. There are some patients that if they've had some type of ingestion or injury, that those patients will need to go to the emergency department to get medically stabilized first. And we did ask our Medical Direction Commission to look at a screening tool because we wanted to provide agencies with a standardized guideline that they could choose to use if they wanted to really make sure that they've screened out patients who may have a medical emergency before they go to a behavioral health facility. So what were the historical barriers? So really the 3 barriers that we heard were, number one, to EMS transport patients directly to behavioral facilities. And the answer is yes. And here are the revised statutory rules that apply to that. The next question was, can EMS build for transport to behavioral facilities? And again, the answer is yes, because the revised statute was there. And then the third one was, can EMS agencies get paid for bills submitted for these transports? And I think that's kind of what the last barrier to try to address. The specific to Medicaid access, you can see here per the revised statute that there's a specific contract rate that has to be reimbursed that's in rule for these types of transports. So this is really kind of taking a look back and saying, I term this the urban myths and legends of what we can and can't do, and recognizing that we're actually not needing to change rule or statutes. It's a being in rule and statute, and it's really just looking at how can we address this differently. Next slide. So one of the other pieces that we want to do is look to really work synergistically with existing infrastructure. The 988 system and 211 provide a lot of resources out to the community. And I think one of the things to recognize is that some of these patients, if you can actually link in Solari and their crisis response, either specialists on the telephone or with their units, these patients may not need transport anywhere. They have a very high rate of being able to evaluate a patient and determine if transport is needed. So really, Solari can work synergistically with DMS agencies, and they really would like to do that at the statewide level. Interestingly, at the National Association of EMS Physicians Conference last week in Austin, the National 988 program did kind of a all session talk on their program. And it was great to see just how ahead of the curve Arizona is with this. They were very proud at the national level that they've got their time to call answer down from about an hour and 1 minute and 20 seconds to 40 seconds. When Solari came, I think they're at 8 to 9 seconds for their call answer time. So really very impressive data, and just exciting to see that Arizona is at the forefront with this type of work. Next slide. So really want to encourage, if you're not familiar with Solari, again, we've got those slide decks. Thank you to the Bureau team that have updated our Bureau website. So we do have a section now that is alternative destinations and treat and refer. And we have all the resources from our work group meeting that are on the website. So if you wanted to go back and look at Solari's presentation, our access presentation, we have those listed there. But really, this was an opportunity to, as an agency now, hopefully go live with this program and utilize some of these resources. This is the link to the, we don't need to open it now, or we can. That's okay. This is again just the access to Medicaid facilities that are crisis stabilization units. So these are what they call the no wrong door facilities. They will take patients in 24/7. They have both the adult and then ones that will also take adolescents. You see, obviously, you see more facilities in the larger metropolitan regions, but they do have facilities across the state. Again, this is only the access to Medicaid funded crisis stabilization units. The link to the Medical Direction Commission approved guidelines. Thank you to that group for working on this. Again, we wanted to have this available so an agency and the medical director can choose to make some adjustments to this. So we wanted to have a basic standard to at least help make this easier for agencies who want to implement the program. So this is also available on the website. And then lastly, we had a follow-up meeting with the health plan. But interestingly, they actually reached out to the Bureau saying that they heard about our meetings and our subcommittees and really wanted to kind of meet with the EMS agencies and get further input. And so I think it was a really productive meeting for them to hear some of the historical barriers that have occurred in terms of getting to that reimbursement. After that meeting, they actually followed up recently with a couple more questions for me to clarify that I provided some answers to them about. So I think we are seeing some really good engagement with this. Access is very invested in this program. They were active participants in helping to kind of get these meetings moving forward. So we really discussed a lot of these kind of barriers regarding reimbursement at the third stakeholder meeting to try to figure out how can we best address this. But it's nice to see that, again, many of these patients are going to be on Medicaid. We have the contract rates that are in statute already. And from the private health plan perspective, they are very interested in this program and did follow up with further questions. So the hope is at this time that as an agency, if you would like to implement this program, to really start working with your billing department, seeing if you've tried to implement any of these, if there's any barriers, we could certainly schedule some follow-up. I think it's a good time to launch at this time. So I think that was my last slide, and I will open it up to any questions. Yes, Dr. Gaylor?
Shelley, could you please go back to that slide right before the crisis response centers where it talked about EMS could engage Solari and 988 services at the scene. Okay. In my estimation, this is, first, thanks for all the work the Bureau did on those 3 meetings. They were great, very informative, very on point, and easily understandable. The activity described here, I interpret this as it relates to the new statute 36/2219 regarding EMS transport of patients. This, I think you need to, or an agency would need to classify this in a treat and refer or alternative destination sort of program that they are running. But I think this doesn't contradict statute, that particular statute, if that is indeed understood. And I think I don't know what the ask is here, maybe a guidance document or a substantive policy statement from the Bureau that activities such as this could be termed alternative destination or treat and refer activity for the purposes of compliance with the statute. I think that would be helpful. Maybe I'm the only one who holds that idea, but I just wanted to bring that up for discussion.
I think it's labeled alternative destination, so it's covered in that statute change. And I don't think there's any issues with that. Treat and refer is very specific. So I think this is not necessarily treat and refer. You have to be a treat and refer program. This applies to anyone who would like to go alternative destination. So it's outlined in statute, and this program is defined as alternative destination. And it's kind of listed in that on our website, and all the beats have listed that in the title. I think it's implied with that.
Would you agree that it'd be helpful for a EMS agency to declare in paperwork or notifications to patients that we are involved in an alternative destination program, and we can offer you these services as part of our alternative destination program? Do you think at aid in future questions whether there was compliance with 2219?
I think 504
504 covers
504 covers that in the rules. That's particular on this alternate destinations, and since it's an alternate destination, it's all just it tells a lot of stuff about the patient has to choose it. You have to, do different stuff with them. But it seems like since this is being included as an alternative destination, that 504 is the information that you would get to be able to apply that.
I'm thinking of the legislative intent with that statute, and I think the legislative intent was transport to an emergency department shall be offered if the patient wants it. And so I think appropriate wording is suggestion for all agencies to undertake when explaining these type of programs, because let's face it, the typical 911 caller expects to be transported to the emergency department, but they may not need that service. And, this all requires a little finesse, and it's kind of the art of paramedicine to explain. We feel that this other method to get you the care you need is appropriate. And I just want our EMS providers to be knowledgeable or secure in the knowledge that they're compliant with statute rule when they do this. And I think that's why I'm saying that maybe a substantive policy statement or something to that effect might be helpful.
Yeah, Dr. Gamer, I can jump in there and say that under Title 41 that was actually updated a couple years ago, we have limitations on the number of substantive policy statements we can do, especially if something's already outlined in rule. So if it offers, any relief, it is outlined as Brian brought up in rule already. So alternative destinations are specifically outlined and authorized in rule. We wanted to bring us back to this slide because it does reference that authority that is available under 504B. And we wouldn't be able to do a substantive policy statement only because if it's already in rule, it is already there spelled out for us. Hopefully that helps.
And I think this is really education, because honestly, you don't want to take a patient who is not wanting to go to a facility that's not going to be a productive thing. They're going to go to that facility and it's going to escalate 911 to deactivate it. So I think it's more of an education of how you implement this and offer a patient, would you like to go to an emergency department? Would you like to go to this facility or this facility? And that's each agency needs to figure out what facilities are available in their jurisdiction. So some jurisdictions, it's on live, they don't have necessarily a Medicaid funded facility anywhere near to them, but they have private facilities that will take patients. But some patients may elect or are not elect to go there. So I think this is really education piece that is outlined in rule. And I think it's, letting people know we're not actually changing anything here. This is already very well delineated.
Oh, this was useful. I just think appropriate scripting to describe what you're contemplating is informative for the patient, probably out of any questions about compliance and statute.
Let's see the chats that have come. I take Ben. Behavioral transportation providers, technician. I think that is a little bit different patient population than the child household 2066 behavioral transportation providers, technicians might have some of the alternative modalities that we were talking about.
Yeah, Vince, we have not had the opportunity to review that bill that you're referencing in detail yet. But our understanding is the scope there is a bit different than what we're discussing now. And we'll definitely be taking a closer look at that one.
You know, the only thing I can say about that is, boy, it sure is putting a lot of work on the Bureau, because you're going to have to come up with that behavioral health technician, you know, certification and what it means, and even how these transports may be used. You know, is it going to be from hospital to hospital facility, or is it going to be from the scene to an alternative destination? So it's kind of gray, but, you know, it does have the potential to work for us if it does shape up in a way that would be an effective alternative transport.
Definitely a lot of potential implications there.
Yes.
Any further discussion on this? Again, for everyone who participates in these meetings, then we're excited to hopefully see some more progress to this. All right, next I will turn it over to Julia for our next steps for our strategic assessment and planning.
Sure, and I will refer back to the slide. So thank you so much for everyone that's participated thus far in our strategic planning process. So just to recap, last year we did our needs assessment survey. We got over 1,000 EMCPs to participate and just under 100 different organizations to participate. So this month and next month, we'll be working on compiling all of those results and the focus group sessions into a consolidated report so that we can share that out with everybody. The next steps that we will be working on is sometime in April. We're hoping to host a strategic planning summit. So we'll invite people here to ADHS so that we can engage more on strategic planning and help to identify those priorities in development of the strategic plan. We hope to, at the September EMS Council and staff meeting, present a draft version of the strategic plan so that we can get that approved and then work on implementing that for January. And in the Bureau report slides, there is the timeline that Rachel had referenced earlier. So that's available to reference for that.
What's going on right there? There we go.
Yeah, so let's just recap the process. I mean, we've done the survey, we did focus groups. So again, thank you for your participation in those groups and in the survey. And so now we're working on getting that report developed so that we can share that. And then next steps include the summit and getting the strategic plan drafted. So definitely more to come on that, and look for information on an April-ish strategic planning summit to come for this year.
We'll try to get a save the date out, even if we don't have all the details about location, but just to make sure we can get that simple calendar. So we'll work on getting a date planned here, hopefully by the end of the week. That way we can get that on calendars. Thank you. Next, Julia, if you wanted to cover the upcoming EMT of the Year award.
Yeah, so we are excited to continue the work that we started last year in terms of the recognition. So last year, as you are all aware, we had the EMT of the Year awards, and we were able to award 4 different awardees at the EMS Council meeting in May. So we're doing something similar this year. So we'll have the EMT of the Year award, and then we also added on a trauma awards component. So nominations for that are now open. We have some information posted in the little bullhorn section on our website. So we're accepting nominations for that until about March 14th or 15th, so that we have enough time to get that information compiled and announce the award winners around the May DMS Council and staff meetings. So I will go ahead and put those links in the chats for anybody that's interested in participating and nominating an EMCT or somebody for the trauma awards.
And thank you. We do appreciate all the regions for nominating in such a short time frame and getting those awards to us last year. For those of you that were present, that was a really nice time to do some recognition. So we are excited to do that again this year, and also excited that we will be doing trauma award that will be new. It's a little bit more complex to do the trauma system. The regions are easy. We were kind of assigned to each of the 4 regions, but we should be getting quite a bit of communication regarding the EMT of the Year award. So those are live on the Bureau's website currently in the bullhorn, and we will get that out via email communication as well. So we'll have ample time to get those submitted for discussion. Thank you. All right. Next, we are going to turn over to Vauxhall for data visualization at CMS reports. Again, a reminder that we have gone to this Tableau format, for really getting away from doing what we used to have our annual report, which was a PDF document that really we couldn't make a lot of adjustments to over the year. Vauxhall has created this excellent dashboard. The links are in the agenda, so if you wanted to go after the meeting and review any of the data, you can. And I will go ahead and hand it over to Vauxhall as she just goes through each of the tabs to cover them.
Good morning, everyone. This is an annual dashboards I have presented before, but now if we scroll down in the year filter, we have, I think, almost 3 years worth of data in the dashboard. If we drop down menu, we have from 2020 onwards, we have data over here. 2022 got updated recently, and my plan is to update the 2023 year data pretty soon. In a couple of months we will have the 2023 data available also over there. The snapshot gives you the overview of EMS incidents, and we have more than now million records per year. As you see, 1.3 million records total EMS incidents, and the snapshot is basically gives an overview about the mechanism of what are the 5 primary impressions, the county level of EMS incidence rates, and then we do have like prevalence of primary and secondary impression by like top ones, even for the mortality and for the pediatric population over here. Let's go to the pre-hospital incidents. Again, it gives you the distribution by month. It gives you the distribution by time and day of the week. We have a few filters available over here. So we click on the agency type. I just want to talk mainly about the filters over here. So we can look at the report by air and the ground agencies. If you click on the air, and then it changes the distribution that shows you air and EM, and then type of EMS services requested. So it talks about, if you click on, so if you just want to see the 911 or interfacility medical transports, it will show you that. And then the EMS regions are there, and they are divided into 4 regions, and then we can look at the region specific reports. So those are the main filters available, or whenever possible, it's available for all the pages to filter it out. Look at the demographics. Right, we have our urban and rural EMS incident rates, and it just gives you this basic demographics by age, gender, by county, and and then again the same filters are available. Primary and secondary impressions. So we have selected, these are not the only impressions in the year in AZPers. We have selected some of the primary impressions of interest over here to see the incident rates. Maybe you want to select cardiac arrest, whatever you want to select, that's fine. We'll select cardiac arrest, and then it changes. You can see it changes everything for the cardiac arrest. So we had total 18,000 cardiac arrests reported in AZPers. What was the mortality? Over the mortality, there is a dead at scene and died in hospital, and that comes from linking the database with the hospital discharge database. So AZPers were those they were transported to the hospitals. We link the data to the hospital discharge database in order to get the outcome of those cases. So you can see the mortality, in-hospital mortality, and then the on-scene mortality for the cardiac arrest patient. And for any impressions, we can get that. We can go to the injury types. Now, one of the, injury was a big part of AZPers, and so we just selected just the injury populations, and among the injured cases, this is the distribution of like what are the types of injury, falls, and and then when you select any of those injury pattern, it will change. It will give you the age and gender distributions and the county distribution for that particular injury. And then the final tab is on the response times. So response time over here, we have response time is from unit notified dispatch date to this unit arrives on the scene, and then the scene time, how much time they are on the scene, and then the transport time. So these are the three response times given over here. What the parenthesis shows here, response time data missing. So it shows the quality of our data. If we see in the response time, we have only 0.26% missing. So that's very, that's really, really good. We are receiving almost all data on response time. Now the response time is divided by the region, by the county, and then the counties are aggregated, are grouped into the regions to look at the regional level, the pattern of response time. Median scene time, what we'll see over here that we will slightly increase in the percent of missing, 14.8% data is missing. Right, and then the scene time and the transport time. Scene time was a lot missing if I include everybody. So what we figure out in AZPers is that if the patient is transported to the hospital, we tend to have a better scene time data. So the scene time and the transport time, and transport type, obviously, if the patient gets transported to the hospital, then only we are going to have it. But the scene time and transport time are only for those patients who are transported to the hospital. So that mainly for the scene time, mainly it was done to remove the bias of the missing data. So now we have 14.8% missing in scene time, and then you can see that scene time by the county has kind of no meaning, knowing that it will differ from county to county. That does not make any sense. So we decided to give you guys the scene time by the impressions, because some of the impressions will take some time. Some of the impressions are very time sensitive, and you want to get them to the hospital as fast as possible. So that's why I thought that the scene time by impressions would be a better choice than doing by the county. And then the median transport time, the transport time again makes sense that we do it by the county, because depending upon the geographic region, it takes time to transport the patient from one location to another. So then the transport time again, you will see is that it's better, it's broken down by the county. We do have some missing issue about the transport time. We have around 20% of the data missing. That's something which needs to be addressed for the EMS agencies. How do we improve that data? And yeah, I can take any questions. This was just a very, very overview of the dashboards. There are so many other ways you can filter and get the information you need. Obviously, I don't have the time to go through each and every graphs.
Thank you, Vatla. Yes, this is a massive amount of information. So I think for those who remember, we need to also need to produce, I think, like a 25 to 30 page PDF annual report. And really this allowed us to kind of update data as we've seen with the trauma report. When we have requests from that to make some adjustments, look for new variables. Vatla is able to actually run that data in between meetings and update that to the dashboard. So we appreciate everyone taking time to review these. Again, the link is in the agendas. If you have difficulty finding that on our website, you can query down based on kind of the county level data, the types of calls you're looking for year after year comparison. So just a wealth of information there. So a big thank you to Vatla and the whole DQA for all of their efforts with that. Any questions about any of the data piece for Vatla?
Thank you.
Amazing work, Vatla. Good job.
Thank you.
Yeah, and I see your point, Vince. Thank you. Yes, about pointing out really some of our data that we are missing in regards to kind of call time. That really is important. It does have implications with patient care. So the more we can get, hopefully automate some of that data or get crews to click the button so that we can collect that data. It really is important to figure out where we can improve the outcome of patient care. Right, next agenda items to be considered for the next meeting. If you have any agenda items, please let either Shelley or myself know. Call to the public. All right, hearing none, there are a list of upcoming events in the agenda. We also have a link on the Bureau's website. Our next meeting will be May 16th at 10:30 a.m. Hopefully we'll have a good turnout. We will be excited to give out our next round of EMT of the Year award. If I get a motion to adjourn, please.
Motion.
All right, first and the second in the room. Thank you, everyone. Meeting is adjourned.